I'm Rebecca, and I'm here with Mitch today, and we're going to teach Sarah about shock. To start with, we're going to start with hypovolemic shock. Causes of hypovolemic shock. There are two different types, absolute and relative.
So I was looking in the book, absolute is any type of external loss of fluid and relative is any internal loss of fluid, right?
Exactly.
Okay.
So some examples of absolute shock are hemorrhage, loss of other bodily fluids. This can be through nausea, vomiting, diabetes insipidus, diabetes mellitus, or diuresis. And then some examples of relative hypovolemic shock include pooling of blood or fluids, fluid shifts, an example of that is ascites,
Right.
or internal bleeding.
Okay.
So then we're going to move on to the assessment of your patient with hypovolemic shock. What you're going to expect to see in this patient is a decrease in preload, a decrease in stroke volume, and a decrease in capillary refill. And then early on in hypovolemic shock, you're going to see tachypnea in your patient, and then later on that's going to progress to bradypnea. Correct me here, Mitch.
Yes.
You're going to see a decrease in urinary output in your patient with hypovolemic shock,
Right.
and they're going to have pale, clammy skin. Your patient will also likely have anxiety, confusion, and agitation. There will be absent bowel sounds in your patient with hypovolemic shock.
So I get all that, but what's going to be the first thing that I see to go wrong with my patient? What will help me know?
The hallmark sign that you're going to see in this patient is a decrease in blood pressure and an increase in heart rate.
Okay.
And then there are going to be some labs that you need to look at in your patient with hypovolemic shock, starting with a decrease in hematocrit, decrease in hemoglobin, and increase in lactate.
Okay, so the decrease in hematocrit and hemoglobin is for any type of blood loss.
Exactly.
And then the increase in lactic is because there's not a lot of circulating blood, which would lead to an increase of oxygen. So cellular metabolism is impaired, and you're going to change from aerobic metabolism to anaerobic, right?
Perfect.
Okay.
You're also going to see an increase in urine-specific gravity and changes in electrolytes.
All right.
So now for some interventions for hypovolemic shock. We're going to want to ensure the airway.
Okay.
We're going to administer oxygen as needed. We're going to want 2 large bore IVs because there's going to be a lot of fluid replacement needed. IV fluids and blood, and we need the type and cross. And we want to monitor level of consciousness, respirations, heart rate, rhythm. We're going to monitor those vital signs, EKG, output, ABGs, and we want to also take those bowel sounds.
So I've seen you guys put absent bowel sounds is going to be an assessment, and you want to listen to bowel sounds. Why?
Well, we want to also take the bowel sounds because we want to see if the interventions are working.
Oh, I get it, because in hypovolemic, the body tries to compensate and shunt the blood towards the brain and the heart.
Exactly.
Okay.
Now, for pharmacological interventions, there's no specific drug therapy. What we're basically trying to do is replace that fluid volume.
Mm-hmm.
And we may use isotonic or hypertonic fluids for initial volume replacement.
Okay, so looking it up, isotonic fluids would be like 0.9% normal saline or lactated ringers. And it says hypertonic fluids would be like D5W.
Absolutely.
Okay.
And then we're going to use packed red blood cells, fresh frozen plasma, and or platelets may be given too.
Oh, okay. So that's going to help as far as to stop the blood loss and provide hemostasis. And I just looked it up, the 5% human serum albumin works by increasing the plasma volume.
Yes, we may use that as well.
Okay, that makes sense.
It seems like you've got a pretty good hold on hypovolemic shock, so I think that we're ready to move on to cardiogenic shock.
Okay,
Let me know when you get there. Are you ready?
let's go.
Perfect. All right, some causes of cardiogenic shock are systolic dysfunction, diastolic dysfunction, dysrhythmias, and structural factors.
Okay, so I've got in my notes that some structural factors might be like valvular dysfunctions, kind of like stenosis or regurgitation.
Exactly.
Okay, and dysrhythmia is kind of like AFib and stuff like that.
You could be teaching this class yourself.
No, come on, guys.
But
What's the most common one?
the most common is going to be systolic dysfunction or diastolic dysfunction. And with systolic dysfunction, you're specifically thinking of a patient who's had an MI.
Okay.
All right, assessment for cardiogenic shock. First is going to be tachycardia. Then you're going to have a decrease in blood pressure, a decrease in capillary refill, and your patient with cardiogenic shock may or may not have chest pain. Then again in cardiogenic shock, you're going to see tachypnea. When you also take lung sounds, you're going to hear crackles and or rhonchi. You can expect an increase in sodium and water retention, a decrease in urine output, again a decrease in bowel sounds,
Right.
and your patient with cardiogenic shock again is going to have pallor, cool clammy skin, anxiety, confusion, agitation, and possibly nausea and vomiting.
Jeez, that's a lot.
That is a lot. Now moving on to labs and diagnostic tests. So first of all, you're going to see an increase in your patient's cardiac markers when they have cardiogenic shock.
Is that kind of like the troponin and the CKMB?
Exactly.
Okay.
You're also going to see an increase in your BUN, an increase in BNP, and an increase in blood glucose.
Okay. So the BNP is increased because there's some damage with the heart.
Exactly.
Oh.
All right, your diagnostic tests. You're going to expect to have an EKG done. This is to check for dysrhythmias. An echo. This is to look for left ventricular dysfunction. And a chest x-ray to look for pulmonary infiltrates.
Okay.
All right, moving along now to our interventions for cardiogenic shock. Now some of these are going to be the same as with hypovolemic shock. We're going to start with ensuring that patient's airway, and then the O2, we're going to want to keep the SATs at 90% or above PaO2 greater than 60. We're going to need the IV access once again with 2 large bore IVs, and we're going to administer the drugs as ordered and then titrate as needed. We're going to insert a urinary catheter, an NG tube. We're going to monitor neurostatus Q 1 to 2 hours, continuously monitor vital signs in EKG, assess heart sounds for new murmurs, S3 and S4, monitor respiratory status, monitor urine output, and also take bowel sounds.
Okay. Doesn't seem too bad. It's kind of mirroring the same thing.
Yes, there are some similarities.
Okay.
Now, for pharmacological interventions, there are medications that we use with cardiogenic shock. We're going to use dobutamine, dopamine, epinephrine, norepinephrine, nitroglycerin, and sodium nitroprusside.
Wow. So when I